So liver, and then we do put in some endocrine. If you think back to patho, I think that patho does a very good job. What's the question?
Can you send us this?
It's in your email. Did you not hear that? Did you guys all get your email? Okay. So you have to go to your email, it should be in there. I'm gonna post on Canvas all the stuff for this. when you push the button, it doesn't let you do individual, it's a one or all. So I usually do all, and then I go and unpublish the stuff that I'm not supposed to put on there, which there's really nothing that's hiding, it's just stuff that I don't want you to see quite yet. So with the liver, we'll do liver and endocrine, but what I was saying about patho is that, think back to patho when we learned about like the pituitary gland and kind of like the anterior and posterior, that conversation. There was really nothing in that lecture or those lectures when I talked about endocrine that I'm not gonna talk about again. So that's at least reassuring that kind of some of the pathophys, the symptoms you see with like diabetes insipidus, we're gonna talk about that again, because I know it's been a while, but at least it's not the first time you've ever heard it, okay? And then with liver, I feel like we've talked a lot about, just in general, kind of what the liver does with pharmacology, but now we're gonna talk more about some of the end-stage liver and things that could go wrong and things you might have already seen in clinical, okay? So with the liver, we have to think about what does the liver do, because that's gonna tell us what's wrong and how we can fix it. So when we are assessing, think back to health assessment, how do we assess for the liver? We do it every single time, someone complains of pain, we ask where the pain is, how do we know the liver is okay or not? So if we were to assess the person, what would be something we'd do, see?
Jaundice.
Yep, so jaundice obviously is end stage. You're not gonna have, a little bit of liver function that's decreased and boom, you have jaundice. Jaundice typically is bilirubin in your blood that is kind of floating around with broken down red blood cells. That only happens when the liver is end stage, okay? Or you have an acute liver failure, which how would we get an acute liver failure? Something not chronic, but acute. Medication side effects, alcohol intoxication, things like that. So when people have liver that's an acute issue, you have a healthy liver and you did something a fast way, like took too much Tylenol overdose, something like that, where you hurt the liver that way. So with health assessment, we see the person, right, the skin, which area of the body would have pain if there was something wrong with the liver? The right upper quadrant, right? So every quadrant of our abdomen tells us something different, and if we think liver, we think that area. Also, hepatomegaly. If you were to touch the liver and actually assess for it, you could feel the borders. So in a real person that does, or not a real, a normal person that does not have liver dysfunction, should you be able to feel the liver? Not really, no. It's something where you can kind of have them take a deep breath in, exhale, and kind of feel around. You might feel a border, but it's really not likely. So if you're not feeling anything, that's a good thing. If you feel some type of mass in there that's not there, that's a problem. So I always say if you get to your rib cage down here and you're on your back, that's how you would assess, on the back, and they take a deep breath in and blow out, you kind of have to dig a little bit. You shouldn't feel anything. If you do, it's right past that rib. So that rib that's kind of sitting right there, I would go about not even an inch. If you start feeling a mass, go to where you feel it ends, and you will feel the bottom of the liver. So you should not be feeling that. When it comes to what the liver does, pharmacology, medications, what is the liver's function with medication absorption and metabolism, excretion? How does it affect that? It's the metabolism part. In order to break down drugs, I'm not talking urinate them out or to pass them in your stool, but to actually break them down to use the medication, you have to have a functioning liver. Liver has a lot to do with when medications become toxic levels and when they're being used appropriately. So if your liver, a person that has cirrhosis, what kind of things would you maybe envision would happen to the medication dosages? Or even routes for that matter. It could be changed or altered, right? So they're not normally gonna get the high doses that they typically get. We're gonna avoid all medications altogether that hurt the liver the most. So think of the ones we learned in pharm. Your Tylenol, right? Tylenol is just not a good option for end-stage liver. We're just gonna stay away from it altogether, okay? When a liver fails, it's not long that the kidneys are second with that failing. So if you have a cirrhotic liver, kidney problems follow pretty significantly after as well, okay? And they call that hepatorenal syndrome, where basically your liver fails, here comes your kidneys with it. Okay, what other things does the liver do? We talk a lot about this when it comes to, I don't know, cardiac seems to be a pretty big one, or even kidneys. What are these? I've talked about these before. large amounts, they have to either get them synthetically, we give them through medication or food, or potentially they might get to the point where they don't make it at all and you could have bleeding issues. So little babies tend to have pretty immature livers, they have immature everything. But a lot of times they're not producing that vitamin K quite yet. They rely on mom to pass it through breast milk or to have formula. And so they actually give a vitamin K injection when they're born to help with that clotting process. Okay? What is probably one of the things with liver that is pretty big when it comes to metabolism? We talked about it with diabetes. It's how a lot of our diabetic drugs work. What kind of things does it do with diabetes? Or in that kind of neutrality for diabetic patients? It's where glucose is stored, so or even produced if it needs to. So this is why if you destroy your pancreas from, let's say that islets of Langerhans is destroyed, and glucagon is not being produced in adequate amounts, your liver can kind of kick in and help. Or if you eat a big meal, your liver will store it for when the times that you do need it. So that way you're not eating and it's instantly being passed through the urine or the stool. So if your liver is dysfunctional, you can have some problems with your diabetes if they have that diagnosis too. So what would happen is when the person has cirrhosis, they're either going to not respond to the insulin at all, or they're gonna secrete too much. So you can have various problems, either high or low blood sugars. Typically you'll see more of the high blood sugars because it'll store it, but it's not able to be used, or it just kind of sits there and circulates through the blood. So diabetes is a huge problem. Okay, liver produces bile. What does bile do in our body? If you think about, I don't think I have a picture on here, but your liver, not the best picture, but your common bile duct is gonna go down. A common bile duct is going to feed bile into your stomach, or more into your small intestine, and it's going to help with digestion. The reason why your poop is brown is because of bile. That is why. So if you have people that have gallstones, okay, sometimes when the person goes to the bathroom, they see that their stool is more clay colored or white colored. It's a sign of liver dysfunction or potentially stones inside of there. Because if the bile can't get down into your stool or to your intestine, you're not gonna create that brown color. So the color is more of a clay color. And that's usually a sign of liver dysfunction or a gallstone that's stuck in your your common bile duct. So here's the question of the day: can the liver regenerate? Liver cells. They can if they're healthy cells. So if you have a person that has destroyed the tissues of their liver, and I mean completely, you destroyed your entire liver. So think of people that are having alcoholic cirrhosis, or they took too much IV drug use, hepatitis C, maybe they had an undiagnosed hep C for a long time. These are people that probably have destroyed that tissue of the liver and it causes scar tissue. That tissue is not will not regenerate. However, when we do a liver transplant, do we take one person's liver completely and take it and put it into another person? No, they actually take just a portion of it or a lobe, and it can actually regenerate. So the person that donated the liver, they have a portion missing, they will grow it back, and the person that has the new liver will get that piece and it can grow to what it needs to be for functioning. It's the only real organ that we have that pretty much regenerates, and it's with a healthy cell. So the person that donated, theirs should grow back because they do not have cirrhosis. The person getting it has a new, fresh, lively tissue that can regenerate, but not in scarred or cirrhotic livers. Okay, so if someone gets the diagnosis of cirrhosis, I want to think about all the stuff you know, what you've heard, real or not, we'll talk about it. So when someone says, I have cirrhosis, what's the first thing that maybe comes to your mind? Okay, so it's pretty typical, right? So we think alcohol. Now, in the hospital, I'm not gonna say it's not number one, because it is, but if a person says, I have cirrhosis, do we assume it's alcohol? No, we say probably is, however, if it's not, could it be something else? Yes, of course it can. There's a lot of people that have cirrhosis, never had a drink of alcohol in their life. So we can't just say, oh, you must be an alcoholic. You cannot assume that. Now, I'm not saying that alcohol doesn't have a very close relationship with liver failure. That is absolutely true. There are other causes, okay? We'll talk about those in a second. Other things, if you have end-stage chronic liver disease, anything else that comes to your mind about what you've heard, maybe treatments, assessments? we said jaundice. We talked about hepatomegaly. What other things did we talk about? Or anything that, what's that? Yep, right upper quadrant pain. If you have hepatomegaly, right upper quadrant pain, jaundice, what about liver function? What kind of things did you maybe see for tests here? Okay, your ALT and your AST. So something kind of interesting about ALT and AST. We've always heard of this as being our liver function test, right? So they absolutely will have increases if they are stimulated or there's problems. However, when someone has liver cirrhosis for long periods of time, it's like being compensated. Sometimes they can come back down to a somewhat normal range because they're used to it. Or if the person has been high initially, after a year or two, they kind of come back down because the inflammation is gone now, it's become dead tissue. So I 100% agree that these will be high in immediate stresses or more acute stresses, but as time goes on, these start to kind of go back to normal. Kind of like a troponin for your heart. So if someone had a heart attack, we would know troponin would be elevated. That's like the stress enzyme. But after 2 years after a heart attack, is that troponin still elevated? No, this is kind of the same concept. So we will see this more in acute inflammation rather than chronic. So we have to rely on other labs that say, your liver is cirrhotic, and I can tell that because of other labs that are affected. So not just our ALT and AST. Can you think of anything that, depending on what the liver does, that can be affected?
Bilirubin.
Okay, perfect. So your bili will be high, and this will not be just because of acute or chronic, it's just because you have that jaundice inside your blood. Think about vitamin K. We don't really have a lab, there is, but it's not something you do traditionally where, let's just draw a vitamin K level. We will look for other ways to know if this is low. So if this is in charge of clotting, bleeding, what kind of things would we test for to see if it actually is a problem? Your coagulation studies. This is the #1 way to know if you have cirrhosis, is your coagulation studies. So of course they're gonna draw LFTs, AST, ALT. They're probably gonna draw bilirubin, that's definitely gonna be on that panel, but they're gonna go say, okay, if your cirrhosis is advanced and you're not making any of your vitamins, you should have coagulation studies that are altered to the point where you would bleed, right? So if you think about what the liver does, it makes sense why we draw a PTINR and a PTT, okay? You could probably even go as far as to say H and H, because if they're bleeding, you're gonna have low H and H. Or red blood cells. So a lot of times you'll see on a patient, first of all of these will be drawn, but the doctor or nurse practitioner, PA, will be more worried about their coagulation, because that is how you know if that person is actually end stage or not. Okay? So why does this happen? #1, alcohol is up there. Now, it's probably about 80% of cases, so that does leave 20%. I do think this is gonna be a little bit different in the years to come, because one major component has changed the percentage. Rather than 30 years ago, it probably was more alcohol related. And the one that is kind of coming up more in the prevalence is actually high cholesterol. So if somebody has a very high cholesterol, high fat diet, it is going to cause fatty liver disease. And so we haven't seen that as much as a reason back in like the 80s, 70s, because we didn't have as much obesity. But now that obesity is on the rise, we've had 1/3 of our population is classified as obese, we're gonna start to see more of that fatty liver disease, and it's gonna cause some of that cirrhosis that we see. Now, is alcohol still a problem? Of course it is, okay? But I think there's kind of this stigma that, you know, alcohol is bad, but people are still kind of stuffing their faces with excessive calories, which in reality, the obesity probably causes just as much issues as the alcohol when it comes to problems with the liver and other problems in the body. Biliary cirrhosis is more of an acute issue, so if you have, I didn't have my picture anymore, but that common bile duct that comes down from your gallbladder and your liver, if you get someone that has a biliary colic just means a blockage of some sort. Think about little babies that cry all day, they have colic. What do you think their colic is related from? When I think of colic, it's usually GI, like they might have constipation, some blockage in their stomach that's causing discomfort. So if you ever see the word colic, it's usually a pain that people feel because of a blockage of some sort. So biliary, we know the biliary duct, if you have blockage of that biliary duct, whether it's from a stone or constriction, we've all puked up bile, right? That feeling where it's like acid, from your stomach and that bile and you've tasted it, it does not taste good. Imagine if that bile sits in the gallbladder or sits in the liver and does not move. It's gonna cause necrosis. This is why usually gallbladders typically are the first thing to go when it comes to people that have a gallstone, right? They have a gallstone that's stuck, the bile stays behind, causes that tissue to erode, and it causes that necrosis. Same thing can happen in the liver. If people have chronic gallstones or chronic biliary colic, they could have issues with cirrhosis. And then the post-hepatic cirrhosis is more for like your hepatitis patients. So someone that might have not known they had hepatitis or they had hepatitis C for 10, 20, 30 years, and it could result in cirrhosis if they do not get it fixed. So is Hep C at this point in time curable? The answer is yes, but remember how much it costs. Remember my uncle? It costs $30,000 a month. So if someone wasn't as lucky to provide or get that treatment, you could have issues with compliance and not be able to treat it. Hepatitis B. We all in this room should be vaccinated against Hep B. However, if you were to get a diagnosis of hepatitis B, it's just as bad as Hep C and can cause cirrhosis of the liver. So hopefully you'll never have to experience that because you're vaccinated. But not everybody gets the vaccination, so they could get Hep B. How do we get Hep B and C? Like, what are ways to prevent hepatitis C and hepatitis cirrhosis? First of all, get vaccinated. There's a vaccine, you should take it, right? That's one perfect way to do it. However, another way would be to perform or to provide safe sex, right? Making sure you protect yourself. Needle sticks in the hospital for healthcare workers. You are at an increased risk for exposure because of your risky job. IV drug use, that would be another way that people in the public would get it. If they were not vaccinated, they could potentially get it that way. What is the percent chance that you would get Hep C from a needle stick if the person was positive for Hep C? What is it, Sydney? It's actually high. HIV is 0.3%, so very low. I still don't want the percent. 30% Hep C, 1 in 3. So Hep C is heavily transferred by blood. Okay, remember my story with my uncle where his obviously wife and him were not practicing safe sex for 30 years. She never got it, okay? But IV would go into your blood, or if you got a needle stick and that went into your skin, you'd have a higher chance of getting it that way. Yeah, some people are like, oh, I'm so scared of getting HIV from needle stick, but it's really Hep C that you should be worried about. It's 30%, it's very high. So what kind of high-risk behaviors would we try to avoid to not get cirrhosis? Sexual behaviors, right? Unprotected sex, but also IV drug use. Those are number 1, number 2 there. Okay, so what's the difference between early and late stages? Ironically enough, in early stages of cirrhosis, people tend to not really know that they have an issue. So you could be having a patient that is an alcoholic, who's been an alcoholic for 20 years, and they probably will end up with a cirrhosis, but some of their initial symptoms are not like blaring out loud, I have a problem. They might feel a little nausea in that beginning stages, or possibly a little bit of achy pain in their liver, but they're gonna play it off probably as something else, right? So the first thing, that if you have stomach pain, little nausea, you're probably not gonna say I have cirrhosis. So some of those things are typical, that it gets to the end stage before they notice something's wrong. The biggest thing that you as a provider or a nurse, and they come in and they complain of a sign, is gonna be something you report. Weight loss that has not been initiated by diet or exercise change. So if any patient that says to you, one of the questions you ask on admit as a nurse is, have you lost any weight or gained any weight without trying? Because loss of weight without trying can mean a plethora of things, but one of them is typically liver or organ problems, or if you have cancer of some sort. It's not common to lose 15 pounds in a month or 2 without trying. So those are things to investigate further. Now, patients that have cirrhosis, now I'm not saying that this is the only way, but alcoholic cirrhosis, what is their diet like as an alcoholic? It's alcohol, right? That's pretty much what they drink. So a lot of times alcoholics do not have a diet. First of all, they're malnourished, but they don't eat like we eat. They don't eat 3 meals a day, snacks, whatever. They wake up and crack a beer. That's what their diet is like. And so if you have people that are actual alcoholics that drink all day long, they're gonna have very low amounts of food, which causes them to lose weight, right? So this loss of weight may not be totally out of the question. They'll say, well, I don't eat really, I just drink all day for my meals, okay? Or you think, how can someone lose weight and have a case of beer a day? But that's all they have, is that case of beer, maybe a snack here and there. So when the early stages present, you might see it if you go to the doctor, might not. Treatment that you do have during the liver cirrhotic process is we treat the symptoms. There's no cure for cirrhosis. Once you have damaged your liver, it's gone, it's done. So what is the end all here that may help if you are lucky enough to get this service? A transplant, which probably is not going to occur in 90% of people. There was a person down in Parkston last semester, I think some of you had this lady, and she has cirrhosis at the age of like 40. Remember her? Yeah, she was that was end stage, that's it, that's the end. Is she going to get a liver? The answer is no, unless she's changed her ways, but you have to make sure you are not drinking for 6 months' time. If you drink in that 6 months' time, your clock starts over. And you can't even get on the list until you've been clean for 6 months. So you can't say, I'm gonna quit today, put me on the list, maybe at the end of my 6 months, I'll be on getting my transplant. That's not how it works. But a lot of times if people are end stage, to the point where they need a liver, 6 months time is a long time for someone that has a liver that's not functioning. And we don't have something like dialysis for kidneys to help your organ that's failing. So you have to rely on, hopefully they get to a stage when they do need it, that they're almost to the point of end stage, but they're not too far past. They have to be sick enough, but not too sick, because they won't live with a new liver. More likely reasons why people would get a liver is acute liver failure. So people that had, they got shot in the liver, like a gunshot to the liver caused liver failure. They overdosed on Tylenol and they had a healthy liver to begin. Those are the people that would potentially get a liver over someone that has chronic liver failure. Also consider age. Now I know that lady was only 40, something young, but a lot of times liver failure, it's because they've been drinking excessively for years. So typically these people are not 20 years old. They're like 7 years old. And they've done it to themselves for 40 years, and they finally are having the cirrhosis. Most of the time, liver transplants are not done over the age of 65. Now, is it always the case? No. But in the majority of cases, a lot of physicians will not give you that liver after 65. What's the rationale? Why can't they get a liver? So is it just because they're being cruel because you're older? No, it has to do with the quality of life that you get this liver. So A, you have to meet the criteria, but if age is the only thing keeping you off of the criteria, they look at if a 20-year-old versus an 80-year-old. Okay, this person's probably gonna live another 50 years. This person might live 5, or if they have diabetes and hypertension and all these comorbidities on top of it, are we gonna give a liver and they're gonna die anyway in 2 months, right? So we have to think about, is this person gonna use this liver to the way they're supposed to? Is there any way to know? No, we are not God, okay? So we don't know when someone's going to use it or not. Could they relapse when they got their new liver? Of course they could. So we have to consider, they do a psychological evaluation on patients to see if they are psychologically ready for a new transplant as well. Finances, being able to pay for some of the cares after, it's all considered. Okay, with conditions that can go wrong. So this was kind of the down and dirty and pathophys of when you have liver failure, of course all the things we just talked about can happen, but then this is the point where you get to end stage and you start to see these symptoms. And really there's one major thing that causes a lot of these issues, and it's portal hypertension, okay? So you could probably argue and say, because of portal hypertension, all of the following are going to result. So what causes this hypertension that's in the portal vein? Okay, this cirrhotic liver becomes really stiff, and so do all the vessels that are within it. It's kind of like hypertension. We get atherosclerosis. It's the same concept. The longer you have this problem, the more stiff this vein becomes. And so this vein that gets very high pressure inside of there is going to backflow, or the blood is not going to circle like it normally does, and it's going to be shunted to different areas. So the first thing that it does is it shunts over to your spleen, which if we look at our anatomy here, I already drew all my organs, but I'm drawing again. hypertension, blood gets shunted back here, and if it's not flowing the way it's supposed to, blood just kind of sits. What happens to warm blood as it sits and it doesn't move as good? Not necessarily clots, but the temperature of your blood is 98.6, well it should be, right? And if blood isn't constantly moving, it's still moving, so it's not clotting because it's not that slow, but if it's not moving as fast, heat from your blood will kill the cells in your spleen. So what are things that are inside of our spleen? Our red blood cells, our white blood cells, and your platelets. So what happens is this blood that is warm will sit there and cool. Have you guys ever heard of a testicular torsion? It just reminds me of that, or varicocele inside of the testicles. What happens is the heat from the vessels or the vein kills testosterone because it just sits there. So blood cannot sit for very long periods or else it starts to kill the cells that are there. It's the same concept with any blood in the body. If it sits in pools and it's very warm, it's going to cause irritation. So red blood cells, white blood cells, and platelets, because your spleen, what does it do? It helps with filtering those things out. Or if you have, things that need to be cleaned up, it's kind of the housekeeper of the body. So when these sit there, all these will be low. Another reason why patients who have cirrhosis bleed, because now they have vitamin K deficiency, because their cirrhosis liver does not work, so that's one whammy. Then the blood from portal hypertension pushes up to your spleen and causes red blood cells and platelets to decrease. Another whammy. So now their biggest risk here, a lot of it, is bleeding. So they are not going to be using any type of sharp materials on their skin. They're going to avoid IM injections. We do not want to do IM injections for people with cirrhosis. We try to find other ways. We try to put oral medication or even an IV that's a one stick, and you can put meds through there without puncturing their skin every time, is better than doing like Lovenox injections or an IM flu shot. We have to consider the risk versus the benefit. Another thing is when they shave. What would we avoid to prevent injury here? Use like a electric razor, right? Not like an actual hard razor. I don't know what they're called. Not electric. Just what's it called? Like the one that actually has a blade. Well, it's a razor, but it's not an electric razor. I don't know what's it called. Classic razor. I don't know. But one that you actually can see the blade. That's not something they want. Another thing is keeping their fingernails short. Why would we keep fingernails short? They're going to open up their skin and cause bleeding or irritation. So we usually say try to scratch their skin because they can get very itchy skin from being dry. Use the pads of your finger. Don't use your nails. It's going to cause more bleeding risk. So all those would be low. And then from the plasma rich fluid that's in their abdominal cavity, it will kind of pull, since it has protein that's lower amounts, it pulls that protein outside or that fluid into that abdominal cavity. We've all seen pictures of people with ascites where they have those very big bellies, and it has to do with inside of their blood they don't have a lot of protein, and protein is what sucks fluid back into the vessel. So since they don't have a lot of protein, what is that a result of? Malnutrition. They're not eating like we eat, like we don't eat the protein in a good diet full of fruits and vegetables. So their diet has low protein, and if that's cycling through their vessels, the fluid is just going to leak into that third space. So where does it go? Their belly. So the ascites makes them get very fluid filled. What would happen if their belly got so big? What kind of complications happen with that fluid filled belly? We have to relieve the pressure and take it off of there, but what would make them say, okay, it's bad enough, we should take fluid off? Think about what is up here. Your lungs, right? So think about the obese patient that we usually have. And if they lie on their back, their belly kind of pushes their lungs forward. They can't take deep breaths. So what typically happens in cirrhosis patients with really big bellies, they can't breathe. And it gets to a point where they can't take a deep breath, and they cause themselves to have respiratory complications. So if that does happen and their fluid-filled bellies are so big and uncomfortable, it's going to be time to get rid of that with a paracentesis. Get rid of the fluid. But typically it's because of low protein in the blood. The low protein is what usually will kind of keep the fluid within there, but since there's no protein, it just kind of leaks out into that third space. Okay, another way to look at this, portal hypertension. Here's our esophagus. Obviously your esophagus does not attach to your liver, I get that. But what I'm showing you is that the vessels that are within your mesentery area do connect to your esophagus. So if you have portal hypertension inside of your liver, and you're causing that blood to kind of back up into the spleen, the vessels that are connected here will go to your esophagus as well. They also go down below to your rectum. So this is why patients that have cirrhosis will have esophageal varices. We talked a little bit about that in patho, but what is a varicosity of the leg? Like, have you seen people with varicose veins? We all know what that looks like. Now picture that in someone's esophagus, okay? They literally have pooling veins all in their esophagus that at any point, if something sharp pokes it, it could rupture and bleed. So what kind of foods would we avoid in people with varices of the esophagus? Hard stuff. Chips and nuts and things that would poke it, right? We want soft foods or at least manageable foods that will not irritate it. Another thing is, the more pressure you cause in your esophagus, the more chance of rupture. Vomiting, coughing, or like isometric exercises where you're like clenching, right? Those are all increased pressure areas. So can we prevent someone from vomiting? We can try, right, with antiemetics. Or if they have a high risk for nausea, we're gonna probably keep ahead of their nausea so they're not having vomiting. Now, can we prevent it once it's started? No, but we will try our best to make sure that doesn't cause issues. People that have cirrhosis that get a cold, and they're coughing, we might potentially give them more cough suppressants so they're not causing that pressure inside of their esophagus. Okay, so the varices are in the esophagus, but they also are in your colon. What do we call these little varices? In your rectum. Hemorrhoids, right? So hemorrhoids are very common as well in patients with cirrhosis. If you all of a sudden in the stool of the bathroom see a bright red blood, that is hemorrhoids. It's not a GI bleed. That would look more dark in color. So very common. If you Googled right now ascites in a patient, you're gonna see varicosities on their skin and their belly. And you'll see it if you look, because it gets so full of fluid and the vessels in that area of their body are very full of blood. So you'll see kind of like the spider veins on the skin. Okay, it's very common with their stomach. So if you Google ascites, look for that, you will see those spider angiomas. Okay, last thing and then we'll be done for today. Portal systemic encephalopathy. So if you did not know what this was before today, let's try to break it apart to see if we can figure it out. Is there anything in there that looks familiar to you? Encephalopathy, we've seen that before. What is that? It's an inflammation of this body part. Your brain. Encephalitis, encephalopathy, some type of inflammation inside that brain. So what happens is when your liver is usually metabolizing like normal and it stops, we typically release ammonia from our liver to be pooped out. That's how we get rid of it. We poop ammonia out and also inside of your urine as well. But we get rid of it in those two fashions. If you are not able to get rid of that because of liver failure, you're gonna start cycling a lot of ammonia in your blood, which is a big fat no when it comes to getting better. So what happens is the more ammonia that's supposed to be excreted through your kidneys and bowels, where does it go? It goes in your bloodstream and keeps cycling through. If you have a very high ammonia level, your patient's mentality is gonna be the age of a 2-year-old. I don't care how old they are, they will act like a 2-year-old. They won't respond to you, they will be aggressive. It's like the terrible twos, ever heard of those? Okay? Their thought process will not be of adult level. They'll have the mentality to make decisions like a 2-year-old. So they might get out of bed because they feel like it. Or they might just run down the hallway because they feel like it. So that's something where ammonia levels that are high, in this test you do not have to know normals, just know high is bad. You have to think about cognitive function, safety, fall risk, because these patients will not respond like a normal patient that's coherent. Okay? So what do you think the treatment is? How do we get rid of these ammonia levels? I bet some of you have given this med before. I'm just gonna put it in my ascites belly. Starts with an L. Lactulose. Have you ever given this? Anybody? What does it make them do? Poop. Poop, poop, poop. People that are on lactulose poop a lot because that's how they get rid of ammonia. That's high levels in the blood. Okay? So is it normal to have increased stool? Yes, you want increased stool. That means that the person is getting rid of it. What is asterixis? This is a way you can find out, instead of having an ammonia level, because we all love labs, it it tells us a lot. But does everyone get labs instantly? No, we look at health assessment of your body to say, this might be high ammonia levels. Asterixis is how we figure it out. Anyone know how they assess for it? It's a flapping of the wrist. They literally have the wrist, if they go back like this, it's not just a tremor, it actually flickers the wrist like this. So if they hold their arms up, they kind of have a flicking of the wrist. So they sometimes will see that even laying down. If they're kind of comatose, you'll see the flicking of the wrist. And that's a sign, if they're kind of signs of cirrhosis, they should be checking ammonia levels, because those are typically high. I always talk about this show because I feel like there's a lot to say, but have you guys ever seen House of Cards? It's on Netflix. It's a show basically about the President of the United States and all the stuff he endures as being the president. But one of the episodes, he gets shot in the liver, like tries to get assassinated, and he goes into acute liver failure. He does get into the hospital to the point where they say he needs a liver transplant. And of course, the president gets a liver transplant, right? So it makes sense. Ethically, no, that would not happen. He's just like everybody else, that would not happen. But liver cirrhosis, or failure in his case, I was watching the episode, I'll have to find it for you on Wednesday, but they showed him in the hospital bed, and guess what he was doing? He was having asterixis. I about had a heart attack when I saw it, because I'm like, oh my God, they're having asterixis. I can see it. But like, no one in the nation probably knows what that is on the show, but the medical providers are like, that's actually true. Now his was obsessive, it's like this, but still, the concept is there. It was true.
It's a
Sign of ammonia levels being high, which is, in return, end-stage liver. You can only get high ammonia levels if you have end-stage liver. You're not gonna be able to have those issues till the end.